Good morning and welcome to everyone. My name is Gregory Hicks. I'm the principal investigator and director of the Delaware CTR ACCEL program. I'm also the associate vice president for clinical and translational research at the University of Delaware and a professor in the Department of Physical Therapy. On behalf of the entire Delaware CTR ACCEL program, it's my pleasure to welcome you to the ACCEL Community Research Exchange 2021. As some of you may know, I was appointed to become the director of the Delaware CTR ACCEL program on July 1st of 2020. Dr. Stuart Bender-McLeod, who was the director and driving force behind this program, decided to step down and retire after 8 years of successfully leading this program. Stuart was my professor many years ago when I was a graduate student at the University of Delaware, and he was also the one who recruited me to come back to Delaware as a faculty member. For so many reasons, I am grateful to Stuart, but I am particularly grateful to Stuart for his leadership of this program and for his desire to see clinical and translational research efforts grow within the state of Delaware. When I agreed to take on leadership of this well-established program in late 2019, I couldn't have imagined what 2020 would hold in store for all of us. I don't think any of us could. I certainly didn't see a global pandemic on the horizon. And while the pandemic has certainly impacted how we achieve our mission within the context of the Delaware CTR ACCEL program, we have remained single-minded in our goal. And that goal is to build statewide clinical and translational research infrastructure that will ultimately lead to improved health for all Delawareans. Our program's continued focus on this mission, in spite of COVID-19's impact, is truly a testament to the grit, the determination, and the stewardship of our entire Delaware CTR ACCEL community. And I have to say, I'm very proud to be part of this group who has shown such resilience as a team. A perfect example of that resilience is today's ACCEL Community Research Exchange 2021, which now comes to you in this virtual format. Under the leadership of our esteemed conference co-chairs, Drs. Pachter, Saunders, and Phan, ACCEL is able to bring you a conference that is focused on COVID and the community. This is such an important topic for our community, given that our nation's response to COVID-19 has demonstrated that there is privilege even within a pandemic. According to data from the Nonpartisan APM Research Lab, as of February 2nd, 2021, Black and Latinx people in the state of Delaware are dying from COVID-19 at rates that are 1.7 times and 1.9 times higher than their white peers, respectively. Not all members of our community have been impacted in the same way by this pandemic, and this fact certainly highlights the need for our entire community to be fully engaged in all aspects of clinical and translational research. I'm very grateful to our conference organizers for the careful attention that they paid to addressing the challenging issues of COVID in our communities. At this time, I have the pleasure of introducing one of our conference co-chairs, Dr. Lee Pachter. Dr. Pachter is a senior physician scientist and director of mentorship and professional development at the Value Institute at Christiana Care, and he is the co-lead of the Delaware CTR ACCEL Community Engagement and Outreach Corps. Without any further ado, I'm going to turn things over to our conference co-chair, Dr. Lee Pachter. And once again, welcome.
Thank you, Greg, and welcome everybody. Good morning. On behalf of my conference co-chairs, Marlene Saunders and Omar Khan, I'd like to welcome you to the 2021 Delaware ACCEL Community Research Exchange. This year's conference, as Greg said, is like none before for obvious reasons, for a number of reasons. First and foremost, this is the first CRE that's virtual for obvious reasons. I'd like to thank a group of people who have been working tirelessly to make sure this conference is presented without a hitch through a technology we've never used before for such a large event. So many thanks to Deborah Reese, Karen Huff, Suzanne Perfield, and Keegan Conlon for doing all the work behind the scenes. We really couldn't have done this without you. Also, thanks to George Watson and the University of Delaware Media Services Department. Secondly, as with past CRE conferences, this year's meeting is based around a theme. And not surprisingly, this year's theme is the COVID-19 pandemic. But since the CRE was developed to highlight ACCEL's commitment to community-engaged research, We've tried to address issues pertaining to the pandemic that directly influence the lives of those in the diverse communities and populations that make Delaware the special place that it is. So you'll be hearing about work having to do with issues such as equity regarding vaccine distribution and how we can lessen the impact of vaccine refusal, about the impact of the pandemic on families and healthcare delivery, about community priorities and perspectives on public health and healthcare, about addressing COVID-related emotional distress and new approaches to healthcare delivery, such as telemedicine, through the lens of equity. Let me give you some background about how the ACCEL CRE is able to present such work today. In April 2020, within weeks of the beginning of the pandemic, the Executive Committee of ACCEL decided to turn on the dime and develop a funding mechanism for rapid research on COVID. The 4 research presentations you'll hear today, as well as some of the virtual poster presentations, are a result of ACCEL's rapid COVID funding mechanism. So think of this, within a mere 10 months, we've had a request for proposal, submission of proposals, a review mechanism, project selection, and the actual completion or partial completion of the research. That's pretty amazing in 10 months if you think about it. Major props go out not only to the research teams, but in particular to the Executive Committee of ACCEL, including major shout outs to Stuart Binda-McLeod, former PI of ACCEL, and Greg Hicks. Okay, a few housekeeping notes before we start. I assume because you're home, you don't need to know where the exits or the bathrooms are, so I'll leave that to you. To download today's program booklet, please go to the following link and click on the button titled Program Booklet. It has all the information about the presentations, the presenters, and the posters. And the link is right there. Okay, with regards to questions to the presenters. If you have questions, please use the Q&A button, not the chat button, at the bottom of your screen to submit questions. We probably won't have much time during the conference to answer the questions you propose. But after the conference, everyone registered will receive a follow-up email with a compiled document of all the questions and answers. And please don't forget to visit our virtual poster gallery at the links listed in the program booklet. What you can do is you can view the list of research projects and click on any of them to view the poster and hear a brief audio presentation by the investigators. It's amazing. The breadth of research is really inspiring. And finally, after the conference, we'll be sending everyone a post-CRE survey in a separate email after the conference. Please take a moment to complete it. We really need your feedback on how we're doing and how we can improve the conference. So we're just about to hear the first presentations, but before we begin, please allow me one more minute to highlight an issue that's of central importance to ACCEL, and in particular, the community engagement and outreach core. In all that we do, we try to keep diversity, equity, and inclusion at the forefront. So I'd like to highlight this in 2 ways. First, I'd like to start the meeting today with a brief land acknowledgement. Next slide, please. A land acknowledgement is a simple but powerful way to acknowledge that we live and work on land that was once inhabited by indigenous peoples. It's a way to show respect for the Native Americans who once lived on this land, and it's a step towards correcting practices that erase indigenous peoples' culture and history. We're speaking today from the area that was once the home of the Lenape Nation, who originally inhabited Delaware, Eastern Pennsylvania, New Jersey, and New York, and who were forcefully relocated against their will to Ohio and eventually Oklahoma. So I encourage you to learn about indigenous peoples of your area, such as the Lenape, some of whom are still our neighbors. And finally, since this is February, and February is Black History Month, I'd like to start the program by acknowledging a significant figure in the history of medicine who comes from Delaware. Next slide, please. So this is Rebecca Lee Crumper. Next. Rebecca was born in Christiana, Delaware in 1831. She was raised by an aunt in Pennsylvania who cared for those who were ill in her community. Rebecca followed her footsteps and became a nurse, practicing in the Boston area in the 1850s. She was so exceptional that the doctors she worked with encouraged her to apply to medical school. And in 1864, she graduated from the New England Female Medical College and became the first African-American woman MD in the United States. She had a long career practicing in Boston and in Richmond, Virginia, And in 1833, she wrote and published a book called The Book of Medical Discourses, which is believed to be the first medical textbook authored by an African-American doctor. I find it amazing that she's not a well-known name in US medical history, but at least today at the CRE, we're happy to acknowledge her and her groundbreaking career. So thank you. And now, I'm happy to introduce our first two research presentations. Our first presentation is titled, How Does the Pandemic Affect Families? The COVID-19 Exposure and Family Impact Scale, which is one of the ACCEL COVID-19 Rapid Science Award projects, and will be presented by Kazak, the co-director of the Center for Healthcare Delivery Science at Nemours Children's Healthcare System, and professor of pediatrics at the Sidney Kimmel Medical College at Thomas Jefferson University, and adjunct professor of psychology at the University of Delaware. Anne, it's up to you. It's your podium now.
Okay, thank you very much, Lee. It's a pleasure to have the opportunity to talk with all of you this morning about the work that we've conducted as part of the one of the Quick Step projects supported by ACCEL. Next slide, please. This truly was one of the quickest projects that I've ever gotten off the ground. And it's important to recognize not only the Quick Step grant program, but also our Center for Pediatric Traumatic Stress, as well as our Center for Healthcare Delivery Science in supporting this work and the ongoing data collection that we're doing around it. I also want to recognize our multidisciplinary team from Nemours, as well as our colleagues from CHOP and Cincinnati and parent advocates who helped us in the development of the survey. Next slide, please. So my goals this morning are basically to introduce the scale that we developed, which is the COVID-19 Exposure and Family Impact Scale, CEFIS is the nickname for it, to present some psychometric data from our database of users that we've collected and talk some about implications for future research. This will dovetail, I hope, very nicely with the next presentation, which uses the CEFIS in its study. I'm also pleased to say that the first paper from this project is accepted pending minor revision at the Journal of Pediatric Psychology. Next slide. So I guess I probably shouldn't even use the word unprecedented because it's been used so much and we need to find other ways to talk about the impact of the COVID pandemic on children and families. But needless to say, it's very significant and we need to better understand it. At the time that we started this project in particular, there were a lot of opinion pieces coming out and very thoughtful, very good opinions, but there was relatively little rigorous data available about what does this really mean for kids and families. So the other thought that occurred to me when we developed this was that COVID was going to have a significant impact on our ongoing research procedures and our outcomes, and that it would be important to have a way to, if you will, control for that, to understand that in ongoing studies. We also used a medical traumatic stress model to understand COVID. A lot of the work that we do has to do with how pediatric illnesses and injuries can be traumatic, can be perceived as traumatic by families. And it seemed to me that COVID would be yet another illness which has life threat, has extreme disruptions to people, and is going to have a major impact on the delivery of healthcare. So it seemed that a traumatic stress model would be appropriate. Next slide. So here's where we speed it up very quickly, very nimble on this, and I appreciate the work of all of my colleagues and team on this. We developed the questionnaire in 22 days. We had emails going back and forth very rapidly to write the items. There's three parts. The first part is exposure, and this is critical in traumatic stress because we ask, well, what sort of exposures have people had that may be prompting or maintaining traumatic stress responses? So we wrote 25 items. You'll see them as we go on a little bit. They were yes, no responses in order to say, how much have your family been exposed to things about COVID. And these included things, more routine things like school, housing, employment, missing events, and also 5 items that we asked that were directly related to experiences with COVID, from knowing somebody with COVID to actually having a family member die of COVID. The second part were impact items, and wanting to know to what extent these potential exposures had an impact on the family. And that's important to know as well, because we can't make the assumption that because people have had exposures that they necessarily see that as a negative impact. They may in some cases also see some benefit and potential resilience in their experiences. And finally, we added an open-ended question. I'm not going to talk about that today, but I will say that the responses have been very powerful and interesting and important, and more information there than I might have thought we would have gotten. Next slide. So the procedure for the study, we announced it on listservs in April. It is available in English and Spanish, and through colleagues internationally has now been translated into Italian and Brazilian Portuguese. We registered it with the NIH Disaster Information Management Center. There's no charge to use the CEFIS, but we do ask people to register and to share de-identified data with us via REDCap. And of course, that's how we are able to create the database that we're using. The analysis that I'm going to talk about this morning is basically an exploratory factor analysis, an EFA, using principal components analysis for those that are interested in the details of that, to identify the underlying structure of the items. We also looked at the internal consistencies using Cronbach's alpha. Next slide. So the current database includes 135 sites that have registered to use CEFIS and over 3,600 administrations, and that is growing on a regular basis. We have had a lot of interest in the CEFIS from around the world, and you can see there that those are countries that are all using it currently, and we also have a number of translations that are in process. So this is really taken off very quickly. Next slide. The data that I'm going to talk about today and the data that's in the paper that I mentioned is based on 1,800 caregivers from the database. This is only the English version of the CEFIS. We were a little bit disappointed. The Spanish version, we don't have many completed forms in the United States. We have them internationally, but not in the United States yet. So we hope that will grow. It's based on 28 users from 15 academic medical centers in 12 states. And we have a pretty good geographic distribution there on that. Not too surprisingly, the majority of people that completed the CEFIS were female caregivers. We don't know a lot about the sample, and that's the downside of getting this so quickly and getting de-identified data from the sites. We do have general information about the patient groups, and you can see there that the largest group is actually a community-based group. So these are research studies that were conducted through these medical centers using a community sample. The other large groups there are pain, and then you see hem-onc and general pediatrics and overweight and obesity. So we have a distribution of different patient groups. Next slide. So the factor analyses really support the hypothesized scales, and we're very pleased with them. The exposure items fell out into 6 factors. Factors related to COVID-19 experiences, factors about accessing essentials, food, medication, housing, etc., disruptions to their living conditions, if families need to move, relocate, loss of income, disruption in family caregiving and activities, and designation as an essential worker. That was one of the questions that we asked about that. Those families did stand out as having as a separate factor. subfactor. And then we looked at impact, and we found 3 factors of personal well-being, family interaction, and distress. So again, we were very, very pleased with these. We felt that they made sense, and they were all very strong in the analysis. Next slide. I know that this slide is probably a little bit difficult to read, but what you can see is of the 25 items on the exposure, the mean endorsement was 8.7. So, I think that's a pretty significant amount of exposures. And you can see that it ranged from schools being closed and stay-at-home orders, which was over 90%, down to having someone in the family die from COVID, which was almost 6%, which is certainly not trivial, and some there in the middle. So very nice distribution, again, supporting the scale as assessing a relevant number of exposures. Next slide. The impact scale was a 4-point scale, and there you can see the red line is at 2.5, and so you can see that the trend on the items there is in the direction of a more negative impact, and particularly for anxiety, mood, taking care of others in the family, and general sleep and well-being. So those were the more significant negative impacts in the sample. Next slide. We did look at some of the conditions. We looked at conditions where we had medical conditions where we had at least 200 observations and had more than one site. And again, I really wish we knew more about the samples and the people here, but what you can see is, first of all, everything is significant because it's a big sample. But if you look at the mean for exposure there, the community site is much higher really than the others. And I think that's a very probably important finding. And then and also on distress, the community participants had higher distress scores. And then the other group that's sort of consistently elevated is the pain sample. Next slide, please. So just talking a little bit about the future, and of course you're going to hear about the study that links to this, that's related to this when you hear the next presentation from Dr. Phan and Enlow. But we want to continue looking at this and understanding the impact of the pandemic on children and families over time. We also think there's direct effects on healthcare engagement and delivery, which is, you're going to hear some of our plans about, but also implications for other systems as we think about the long-term impact of this pandemic. The extent of exposure that we see in the sample is really, I think, significant and broad, and the impact on families and parent anxiety and mood is something that we need to attend to. There are also important indications of resilience, and you saw this in particular in some of the comments. Some of the comments were very touching in terms of negative impact, but others really spoke to how families are reorganizing, engaging, seeing the benefits, seeing the silver linings. That was definitely very evident there. As I've mentioned a couple times, we really wish that we could have more data about the sample and understand, both to evaluate the CEFIS, but also to understand how we might help various patient and community groups. Our future steps are we're analyzing the data from the Spanish. We hope to analyze the data from the Spanish version when we get more of it. We've also developed an adolescent and young adult version, and we're actually just beginning the analysis of that now. And I think that's going to also be very, very interesting, and includes items in that case more specific to the developmental circumstances of teens and young adults. Next slide. Okay, that is the end of my formal presentation. I'm not sure if I take questions at this point, or we just move on.
Thank you, Anne. If there are any questions, as I said earlier, we'll be compiling them and sending them to the presenters, and we'll be sending everybody a list of the questions and the answers. But thank you so much for your work and for the presentation. So our next presentation is titled The Impact of COVID-19 on Families and Pediatric Healthcare Delivery. This is another ACCEL COVID-19 Rapid Science Award project. And the presenters are Phan, Associate Professor of Pediatrics at Sidney Kimmel Medical College and a research scientist at the Nemours Center for Healthcare Delivery Science, and Paul Enlow, also an Associate Professor at Sidney Kimmel and an Assistant Research Scientist at the Nemours Center for Healthcare Delivery Science. So Doctors Phan and Enlow, the podium is yours.
Hello, everyone. So good morning, and thanks for joining us. We are going to continue talking about, so Dr. Phan and I are going to continue talking about the impact of the COVID-19 pandemic on families and pediatric healthcare delivery, and some of the findings that we present, and our slides will actually build nicely on what Dr. Kazak had talked about before. Next slide, please. So as Dr. Kazak had mentioned, the COVID-19 pandemic has had a significant impact on the mental health and well-being of families. And in fact, you can conceptualize the COVID-19 pandemic as a traumatic medical event that has affected the mental health of children and caregivers. And there's now emerging evidence to suggest that there are actually sociodemographic disparities in how in COVID-19 exposure and impact. So some sociodemographic groups are actually being affected more than others. To build on this, in addition to impacting mental health, there's some evidence to suggest that the COVID-19 pandemic has also started to impact healthcare delivery for both adult and pediatric health systems. Caregivers are delaying seeking healthcare until they or their child are sicker, and they may also be postponing routine healthcare visits. And we're seeing some evidence that there might even be things like decrease in vaccination rates. So while these disruptions in healthcare delivery may be due to logistics like clinics closing or being able to see fewer patients due to COVID precautions, models of medical traumatic stress suggest that the degree of exposure to COVID-19 and the impact of the pandemic on children and families may actually affect healthcare utilization. So currently, most of the literature has started to look at the mental health impact of the COVID-19 pandemic, but less research has examined disruptions in healthcare delivery, and almost no research has examined the association between the mental health impact of COVID-19 and disruptions in healthcare delivery. Next slide. So to address these gaps in the literature, Dr. Phan and I are conducting a study that has 3 aims, and we're just going to be talking about the first 2 aims today. The first aim that I'll be discussing is examining the psychosocial impact of the COVID-19 pandemic on families. Next slide. So in order to accomplish the first aim, we are conducting a prospective cohort study. So we have recruited caregivers of patients who had an ambulatory care visit scheduled at any Nemours facility in the Delaware Valley in April 2020. We used purposive sampling to ensure that our sample was representative with regards to race, ethnicity, insurance, and rurality. We sent surveys to caregivers via text message about 6 months after the pandemic had started, so between October and November of 2020. The primary measure that we were examining is the CEFIS measure that Dr. Kazak described in her presentation. We have a number of secondary measures that we hope to use to examine associations between the CEFIS and things like just general mental health, post-traumatic stress symptoms, family assessment, or family functioning, but we won't be actually getting into those just in today's presentation. Next slide, please. So as you can see, we recruited 2,500 caregivers, which is represents about 10.5% of all eligible caregivers. So we approached 20,000 and recruited around 2,000, which is pretty great. And 16% of all eligible caregivers. So we were actually very pleased our purposive sampling seems to have paid off because our sample is fairly representative of the broader Nemours patient population with regards to race, ethnicity, insurance, rurality, and language. So over the next 4 slides, I'm going to be presenting some of our CEFIS data. And like some of the presenters were talking about earlier this morning, we are very interested in the racial and ethnic sociodemographic disparities and the impact of the COVID-19 pandemic. And so because of this, we have decided to look specifically at disparities. So the results that I'm going to be presenting are going to be stratified by sociodemographic groups, specifically race, echnicity, insurance, and rurality. For those of you who are interested in the statistics part, we used one-way ANOVA and chi-square to conduct our between group comparisons. Next slide, please. So as Dr. Kazak described in her presentation, the first subscale of the CEFIS is the exposure scale. So scores range from 0 to 25, with higher scores indicating more exposure to aspects of the pandemic. So just starting with race and ethnicity, we do see slightly higher exposure scores in non-Hispanic Black and Hispanic caregivers when compared with non-Hispanic White and other caregivers. We also, moving to insurance, we also see higher exposure scores in caregivers with public insurance when compared with private insurance. Although the self-pay score is actually higher, it's not statistically significant. It was only a smaller subgroup that actually had self-pay insurance. That might be why. And then there was no difference in exposure score by rurality. Next slide, please. So moving on to the impact score. So just a reminder, these scores range from 0 to 5, with higher scores indicating more impact more impact from the pandemic. And a score of 2.5 or higher indicates a negative impact, in which we would say that the pandemic has negatively impacted families' functioning. So starting with race and ethnicity, we can see that actually this is kind of like contrary to what we had expected, but non-Hispanic White caregivers had higher impact scores when compared to Hispanic and non-Hispanic Black caregivers. The difference with the other group was actually not statistically significant. We also see that families with private insurance reported higher impact scores when compared with public insurance, and families from non-rural areas had higher impact scores when compared with families from rural areas. Next slide. So because of the way we look at the CEFIS, the impact score, there's 2 ways to look at it. One is just kind of what is your average score, and then the other is the proportion of families who have a score of 2.5 or more, so they have a negative impact. So we decided to look at it both ways. So these graphs show the proportion of caregivers who reported a negative impact. So they had a CEFIS impact score of 2.5 or higher. So the results are broadly the same, but I think it's a nice way to kind of look at the data a little bit differently. So again, we see the highest proportion, or non-Hispanic White caregivers had the highest proportion of caregivers with that reported negative impact. Looking at private insurance, a greater proportion of caregivers with private insurance or self-pay insurance reported a negative impact when compared with families with public insurance, and a greater proportion of non-rural families reported negative impact when compared with rural insurance. Next slide. And so the last scale of the CEFIS is, of course, the distress score. So this is just a scale of 1 to 10, where higher scores indicate more distress. So looking at the distress scores for the different subgroups, we can see that in general, people are hanging around the midpoint of the scale, maybe a little bit higher, which is pretty good. There were no statistically significant differences in the distress score between different racial and ethnic groups. We do see slightly higher distress scores in in caregivers with public insurance when compared to caregivers with private insurance or self-pay. And we do also see slightly higher distress scores when in caregivers from non-rural areas when compared to caregivers from rural areas. Next slide. And now I'm going to hand it over to my colleague, Phan.
Thanks, Paul. So good morning, everybody. So I'll be talking about AIM 2 of our study, which is the second arm of this triangle, really looking at the extent of disruptions to pediatric healthcare due to the pandemic. And to sort of mirror what Paul just presented on the CEFIS, we decided to focus on disparities in these pediatric healthcare engagement metrics for this presentation. Next slide. So to better understand this, we're conducting a population-based case control study using retrospective data from our electronic health record. We're extracting healthcare utilization data for all patients 0 to 21 years of age who presented to Nemours in the Delaware Valley. Our primary measure of healthcare engagement is the rate of completed ambulatory visits, whether in person or by telehealth. So basically any visits that weren't canceled or missed. As secondary measures of healthcare engagement, we'll also be looking at things like time to rescheduling, if a visit was canceled or missed, telehealth visits separately, hospitalizations, ER and urgent care visits, and vaccinations. We decided to compare each month during the pandemic to the corresponding month the prior year. So today I'll be sharing with you data about the primary measure of healthcare engagement during the first 6 months of when the pandemic really started to impact Delawareans, which we defined as kind of April to September 2020. Next slide. So before we look at our primary outcome measure, visit completion rates, I wanted to orient you to our ambulatory visit volumes. So the x-axis for all of these graphs will be months of the year, April through September. And here the y-axis shows total visit volume. Next. As you can see from this green line, we saw anywhere between 40 and 50,000 visits each month of 2019. Next. In contrast, visit volume decreased to around 10,000 in April 2020, and then rose pretty rapidly by June to near pre-pandemic levels. Some of this was the pandemic, but some of it was also our response at Nemours. Next. As you can see here, on March 25th, all non-urgent patient care was canceled through May 8th as we started to figure things out. Next. But as we started to learn more and put the appropriate safety precautions in place, we started to phase back into in-person visits in late April. Next. And then even more quickly in early June. Next slide. So with this as background, I'm going to be looking now at our visit completion rates. Next. So as you can see from this green line, completion rates in 2019 were right around 80% or right below 80% consistently. Next. In contrast, completion rates in April 2020 fell to nearly 20% and then rose pretty steadily so that by July they were back to pre-pandemic levels. Next slide. When we look at visit completion rates by race and ethnicity, we see pretty clear disparities. So in 2019, non-Hispanic whites had completion rates of around 80%. Next. Other race ethnicities a little bit lower. Next. Hispanics still lower. Next. And non-Hispanic Blacks had the lowest completion rates at around 70%. Next. So during the pandemic, these disparities persisted. So while everyone's completion rates dropped dramatically in the first few months of the pandemic, there were still disparities, and these disparities returned to pre-pandemic levels by July. And so if you could click through, we'll see sort of how those disparities played out over time. Next. So next slide. So when we looked at visit completion rates by insurance, we saw actually even larger disparities. So in 2019, patients with private insurance had completion rates of around 80%. Next. Those with public insurance had completion rates closer to 70%. Next. And those without insurance who were self-pay had completion rates around 60%. Next. So during the pandemic, again, these disparities persisted. While everyone's completion rates dropped dramatically in the first few months of the pandemic, there were still disparities. You can click through twice, please. Perfect. And you can see here that the disparities persisted and returned again to pre-pandemic levels by July. Next slide. Finally, when we looked at visit completion rates by rurality, we also saw disparities. So patients from non-rural neighborhoods had completion rates of around 80%. Next. While those from rural neighborhoods had completion rates that were lower. Next. Again, everyone's completion rates dropped dramatically in the first few months of the pandemic, but recovered to pre-pandemic levels. Next. And the disparities between the rural and non-rural populations persisted and returned to pre-pandemic levels by here, more like September. Next slide. So with this preliminary analysis, we can say the following. So 6 months into the pandemic, as Paul described, families in Delaware were still reporting a negative impact of the pandemic on their family functioning and well-being. Next. A smaller proportion of families from disadvantaged populations reported a negative impact, despite having more exposure to traumatic aspects of the pandemic and feeling more distress, which I think is really a true testament to the resiliency of many of these communities. Next. Not surprisingly, pediatric ambulatory visit volume and completion rates dropped dramatically in the first few months of the pandemic, but recovered by July, which again, I think points to the resiliency of the Delaware community and their ability to return to healthcare safely. Next. However, disparities in visit completion rates persisted and returned to pre-pandemic levels fairly quickly. I think this highlights some of the systemic issues that impact access to healthcare that we really need to try and think hard about and address. Next slide. So what's next? So when the grant started in October, we collected our initial round of surveys and did our initial look at healthcare engagement, which is what we presented today. Next. Next. And now we're coming up on a year of living with the pandemic. And so we know that the impact of the pandemic is ever evolving. And so we're planning to re-administer the survey to examine the impact over the course of a year on families. We're also planning to extract a year's worth of EHR data to look at the impact of the pandemic for a year, not only on visit completion rates, which we presented today, but also other measures of healthcare engagement like telehealth and vaccination. Next. Importantly, we'll be looking at our third aim, which is to see if there's any association between the psychosocial impact that the pandemic has had on an individual family and that family's engagement with the healthcare system. We also plan to explore the disparities we just described further, perhaps adding in some geocoded variables from some of the work that we've done with our bioinformatics group to look more closely at community level sociodemographic factors that may be driving these disparities. Next slide. So lots of work still to do. Paul and I wanted to thank our amazing team, which includes our mentors, Dr. Kazak and Dr. Aldifer, our awesome data analyst, Amanda Lewis, as well as a bunch of other colleagues at the Nemours Center for Healthcare Delivery Science. We have great collaborators within the Nemours Bioinformatics Core, who we couldn't do this work without, and have two great research assistants on this study too. We'd also like to thank Dr. Kaplan with the Bird Corps for his help with the proposal, and of course, ACCEL for the funding to complete this work, which we hope will really inform future initiatives to improve both the physical and mental health of children in Delaware. Thank you. And we're happy to answer any questions offline for sure.
Great.
If people have any.
Well, thank you, Dr. Enlow and Dr. Phan. We actually are a little bit ahead of schedule, so if the presenters don't mind, I might throw one or two questions if we do have the time. And to get it started, I think this is probably to Dr. Enlow and Phan. There's a question that said, to what do you attribute the percentage of white families reporting distress from the pandemic when compared to Black and Hispanic families? And I actually have an addendum to that. And my question is, in Likert scale responses, a difference of a 0.25 or less than 1 on the Likert scale, that might be statistically significant, but what's the clinical relevance of such a small difference? And are you really saying that there are differences when it's that small?
So I think that's a great question. I think we've been tossing around like a couple, it's something I've been thinking of. I agree with what you say about some of these differences are, while statistically significant, may not be clinically significant. So one of the things that we're actually hoping to do with our the additional measures we have like some PTSD scales, we have some PROMIS scales of global mental health. Our hope is that we could maybe use that to determine what might be a clinically significant cutoff score, and that might help us make better use of kind of, are these differences actually clinically significant rather than just, you know, a difference of 0.25. So that's kind of the answer to maybe your question. As far as the, you know, what might this difference be to, I'd be interested, or one of the things I would like to do is look at how are families endorsing things differently, different items on the scale. I'm wondering, does the scale maybe perform differently for different sociodemographic groups? I'm also wondering if there are items that are being less frequently endorsed by certain sociodemographic groups that might be attributing to kind of the differences that we're seeing.
This is Anne. Can you hear me okay? Yeah. A couple things. I wanted to reinforce what Paul was saying, and saying that in regard to the CEFIS, since we're still collecting the data, we're going to be able to do more analyses to essentially figure out if there's a clinical cutoff, right? Or what is predictive of higher or lower scores. I also wondered if a couple people have asked about how to get the CEFIS, and that was on my my thank you slide, which we went by pretty quickly. I was wondering if someone could put that back up so people can see that. And of course, I'd be glad to send materials directly to people as well.
And I have one other comment. So on slide 8 of our presentation, we do show the CEFIS impact scores by a clinical cutoff. So we showed percent of patients who reported a negative impact versus a positive impact. Because I agree with you, Dr. Pachter, sometimes, you know, a point something on a Likert scale doesn't really relay the full meaning. And so we did look at proportion of participants who reported a negative impact versus a positive. And actually that's where we saw the most significant differences between the different subgroups. And so 69% of non-Hispanic whites reported a negative impact versus 53% of non-Hispanic Blacks and 48% of Hispanics. So I do think that there's a difference there. I agree with Paul about things to explore. I also wonder if there's a role of resiliency. I think some of our more disadvantaged communities and populations are able to cope and have developed great resiliency in distressful situations. And I think that's something to be explored too.
Great. Thank you. Those are excellent answers. We have one or two questions about morality. So let me just ask two of them and maybe you can comment. Someone asked, is there a scale used to determine morality, or was that determined by the researchers? And then the follow-up question is, why do you believe the rural families are reporting less COVID-19 impact via the CEFIS, yet their healthcare recovery and interactions are much lower?
So I can take a stab at it, and then Paul, if you have anything extras. So we used
Yeah.
RUCA codes. So it stands for Rural Urban Commuting Area Codes. And it was developed by the USDA. And you can Google it, you can look it up online, and I can find a link to it too if people are interested. But it basically looks at different metrics related to like population density and access to transportation, to define on a scale of 1 to 10, based on your zip code, how rural your area is. And so in previous NIH studies that I've done looking at rural populations, the NIH has preferred to use a RUCA code of greater than or equal to 4 to define a rural neighborhood. And so that's the cutoff that we use to define our 2 subgroups. I tend to think in terms of answering the other part of the question that, like we saw with the differences in race ethnicities, I do think that maybe our rural populations have more resiliency, and I would love to look into that in distressful situations. But I do think, there are aspects of our healthcare system that are systemic, so that even if an individual is less impacted by the pandemic, our healthcare system has not met their needs, and there are systemic issues that have not been addressed that contribute to continuing disparities. And I do wonder, especially for our rural populations who live so far away from our healthcare center, if transportation is one of those.
Sure. Well, thank you. And actually, this next question fits in a little bit to what you were just discussing. How might the racial unrest and injustice issues that we see impact how families experience COVID-19 and response to the CEFIS? And now I'll open up to any of the presenters for that.
So I can take a stab at trying to answer that, and then Leah, and if you'd like to jump in, please go ahead. So we didn't include measures of either perceived racism or like that actually assessed the impact of George Floyd, or I think just like the broader kind of unrest that occurred. One of the things that we wanted to make sure is that we were going to be getting kind of as diverse a sample as we could. We wanted to make sure that we weren't going to be excluding families, and that we weren't going to have families not participating in our study. So we had kind of, I think, really thought through how can we make sure that we are able to include these families in our project, using things like text messaging. I know we spent a lot of time talking through different recruitment strategies to make sure it wasn't going to end up biasing our sample. I do wonder, I don't know if we'd be able to actually get at this, but might there be some responding bias because of that? I think it's interesting to think about. I don't know if we're able to actually know if that occurred, though. I don't know if Lee or Annie have any other ideas.
I think as we go forward and look at, specifically with the CEFIS, what happened in scores and impact and distress over the course of the year, I think would be interesting. I mean, we were very focused on COVID. There's no question about that when we started this in March, and I think didn't have the foresight perhaps to consider some of the other factors that could impact the outcomes. But I hope we'll be able to tease that apart a little bit more, or think about going forward as people are using the CEFIS, what other measures or what other ways could we begin to understand the impact of other factors that are people are experiencing.
Great, thank you. There was a question which was probably similar, asking about ascertainment bias. I don't know if you want to comment any more on the possibility of ascertainment bias.
I'm not sure if I fully understand the question. There could be all kinds of bias in the first sample in the study that I talked about, obviously, because we're collecting data from others where we don't know a lot about it. I guess in accessing the big electronic health record data, there's questions of who may have responded or how we're sampling. I guess that would be a question. I'm not completely sure. And I think that we can, as we dive in and analyze it more, we can look at that and try to determine any biases that were in the sample. I don't know if Lee or Paul have other thoughts about that.
Yeah, I mean, I think we tried really hard to be thoughtful about the survey that we administered for this second study. I think Paul presented some data on the cohort, and it was really a representative sample of the population at Nemours. We really actually sort of oversampled for some of our more disadvantaged populations to make sure that we got a representative sample. And in terms of our kind of survey methods, we actually chose to administer the survey by text to make it really accessible for different populations who may not have access to email or our patient portal, for example. We really try to be thoughtful about it. So I don't know if that helps answer that question, but just throwing that out there. Paul, I don't know if you have any other thoughts.
Yeah, I don't have like anything, I think, groundbreaking to add. I do think that, like Lee said, we had oversampled and it seemed to work pretty well. I do know that we got a pretty good, our responses were pretty diverse, if that makes sense, where it seemed to be that we weren't, we had families reporting, all across the distress scale. We had families reporting all across the exposure and all across the impact scale, which makes me hopeful that we don't have any issues with either sampling bias or ascertainment bias. Obviously, I think it's something that we can delve into a little bit more. I think hopefully we can also start figuring out maybe comparing the families who did participate with those who were eligible to participate with some of the EHR data. I think just because of our sampling method, unfortunately, we're not able to, we have to rely on kind of the EHR data that we have available to kind of probe and prod to see if there might be anything else going on.